Thank you very much. I know everybody's heard the joke about Unclear Medicine. When we were putting together all of the talks, one of the admin goes, "What are you talking about?" I said, "Don't worry. All the primary care doctors will know what we're talking about when we say it's unclear, and I'm going to try to help you clarify some things today." I don't have any disclosures, although my mother did give me some money for my birthday. I think that doesn't count. Nuclear medicine is a division of radiology that uses radiopharmaceuticals for diagnostic and therapeutic purposes. We actually put the imaging agent in the patient and then measure what comes out of the patient, somewhat different than the other modalities that you've heard about. We also happen to be one of the most expensive modalities. Now, I know you're going to find out that's hard to believe, those fuzzy pictures that we generate that sure shouldn't cost that much money, but it's actually very expensive because the radiopharmaceuticals can be very costly, and they're also very labor intensive. Many of your patients that you refer for nuclear medicine exams may say, "We had no idea that it was going to take so long to do this scan." Well, we're relying on physiology, and sometimes it takes a while for the physiologic event to occur so that we can do the imaging. The thing that we do best is the physiologic change, which may often happen in advance of what's changing with... Okay, sorry. Is that better? Okay. We can show things that change in physiology before the anatomy of the structure may change. But in a primary care setting, we may not always be the first modality of choice. This is an example of how physiology can be very helpful when you have an insufficiency fracture. This is typically some little frail old lady with osteoporosis or osteopenia who sits down hard and then develops pelvic pain. And this is what, among radiologists, we call the Honda sign of sacral insufficiency fractures. She has fractures through the sacral ala bilaterally and transversely across the sacrum, somewhat looking like the Honda sign. And this can be a very painful condition and is often difficult to diagnose on plain radiographs because these are really small linear fractures, and in the setting of osteoporotic bone can be hard to see. However, bone scans are very useful for this purpose. And once again, a theme that you're going to hear all day today is American College of Radiology Appropriateness Criteria. And these, as Dr. Bishop said, these are based on evidence-based guidelines to assist ordering physicians in ordering the most appropriate exam. These criteria were developed by expert panels of radiologists and radiation oncologists, and I do hope there were some nuclear medicine specialists in that group. And they were based on evidence from the literature or expert consensus. These criteria can help radiologists and clinicians ordering examinations. And this is an example, when you go to the website Dr. Bishop referenced, that you may say, okay, I want to know what is best for acute chest pain in the setting of suspected pulmonary embolism. And what they do is they rate the criteria from 1 to 3, which is not usually appropriate, 4, 5, and 6, which may be appropriate, and 7, 8, and 9, usually appropriate. So the first thing it says is get a chest x-ray, because sometimes the answer is on the chest x-ray, and you can bypass the more involved, more expensive, more radiation exams. The next one suggested is a CTA with contrast, and it says currently this is the standard of care. Well, it is a good examination. It's currently done about 6 times more than a ventilation perfusion lung scan. And some of that has to do, not that it's that much better examination, but oftentimes it comes down to, if you're doing this at off hours, there's usually a CT tech in-house where a nuclear medicine tech is not. And you're going to have to call them in, and it's going to take more time until you get the answer. However, if you look at this, these little symbols are supposed to indicate the amount of radiation, and they've got equivalent symbols for the 2 of these, but according to our physicist here, the VQ scan is actually about half the amount of radiation that the CTA is. And it's very useful in the setting of people who can't really hold their breath well, so to be able to do a CTA, and you can imagine somebody who's short of breath or having chest pain may be huffing and puffing, and that's really difficult for them to do. It's also useful in the setting of renal insufficiency, where you don't want to give intravenous contrast or you can't give as much as you would like. This is a very busy slide, and it's essentially talking about, okay, now we have chest pain in the setting of acute coronary artery syndrome. What's the most appropriate exam? Well, number one is a multiplanar SPECT scan, rest and stress. Well, obviously in the middle of the night, you're not going to be doing a cardiac stress test, but it is a very good examination because, again, it can show physiologic changes before you have anatomic changes. It does result in a fair amount of radiation, although that can be significantly reduced if you change the way that you do the protocol. In some settings, people only do the stress exam first, and if that's absolutely normal, then they don't do the resting examination, so you can reduce the amount of radiation in that situation as well. Dr. Bishop was talking about right upper quadrant pain. The first place to start is with an ultrasound of the abdomen. Cholescintigraphy is down in the category of may be appropriate, and most of the time cholescintigraphy only occurs after somebody's had an ultrasound and it was somewhat indeterminate about whether there was acute cholecystitis, or the situation where it's not really suspected that the patient has acute cholecystitis but may have something called gallbladder dyskinesia or one of the dysfunctional syndromes. And then we give cholecystokinin to try to make the gallbladder empty, and in some patients that it doesn't empty well, taking out their gallbladder can be therapeutic. This, by the way, is a multi-hour examination, and again, with CCK, so not something that you do on an emergency basis because that's not an operative emergency. In the setting of osteomyelitis in patients with diabetes, soft tissue swelling with or without neuropathic changes, where is the place to start? Well, that less expensive foot x-ray would be helpful, and sometimes the answer's on that right off the bat, but many times with patients that have this scenario, they have a lot of neuropathic changes. They have Charcot joint, the bones in their feet look like cornflakes, and it's really hard to tell if you've got an infection present or not. The next recommended exam, if the patients can get it, is an MRI of the foot, and down here, a whole lot lower are all of the things that I have to offer. My beloved three-phase bone scan, tagged white blood cell study, all those things. Now, in a combination that has been researched here, one of the exams that we have found very useful is the combination of a tagged white blood cell study and a sulfur colloid bone marrow scan. But this, again, this is a multi-day examination. It's a quite expensive examination. For us to take somebody's white blood cells, send them out to be tagged and brought back, that cost us $1,500. So it's a very, as I said, this is an expensive examination, but it often is very, very helpful in the setting of an indeterminate result from other imaging. Now, the ACR puts in their 2 cents about what is appropriate, and Medicare puts in about 50 cents for what is appropriate. And Medicare regulates nuclear medicine probably more than anybody else. And they're very restrictive, particularly in PET-CT imaging. If you've had the encounter of trying to order a PET scan, we ask you a million questions, and some of them have to do with whether or not Medicare is going to approve that, because as Medicare goes, so go most of the insurance companies in terms of what they deem appropriate. So Medicare will cover for the diagnosis, staging, and restaging of any cancer, with the exception of prostate cancer. And the reason for prostate cancer being excluded is most prostate cancers do not take up very much fluorine deoxyglucose, so they're not very helpful diagnostically. There are, however, now limits on the number of examinations that you can get when a patient's being treated post-staging, and these went into effect last year, and essentially Medicare tells you you're only allowed 3 scans unless you want to do a peer-to-peer review with the local Medicare folks. It will cover for the diagnosis of a solitary pulmonary nodule. Dr. Brewington said 8 millimeters. Medicare's got to make it difficult and say it has to be at least 1 centimeter, and it really has to be a solitary pulmonary nodule. So if you have somebody with a setting of multiple pulmonary nodules, at least with Medicare, not all the insurance companies go this stringent, but you may have trouble. It will cover for the diagnosis of dementia. Now, this is fluorine deoxyglucose PET, and we'll come back and talk about some of the amyloid imaging agents as well. but they often require that you have had an extensive clinical examination. That is, you've had a mini mental status examination, a neurologist has examined the patient, and there is some question about what is going on with the patient. Something that I've never understood about Medicare is that we'll cover for seizure localization. Most of the patients that are doing this are way younger than the age that you would be looking for Medicare, so I'm not sure how that got included in the group. And here's an example again of the appropriateness criteria showing probable Alzheimer's disease, but I put a note down here. It says this is also appropriate for other types of dementia, frontotemporal dementia, dementia with Lewy bodies, and really it should be used as a problem solving. Either there's a question about which of these does the patient really have, or do they have anything at all. So it's in the probably category. MRI gets a higher rating, but MRI doesn't show you physiology in quite the same way that we do with FDG PET. A lot of times patients who are older may have some atrophy, and MRI will certainly show you that. But it's really the pattern of FDG distribution that helps us with the diagnosis of dementia, and it can be used to distinguish among different types of dementia. Here is the solitary pulmonary nodule, high up on the list of being appropriate for a solitary pulmonary nodule. There are some problems with FDG and solitary pulmonary nodules, and that has to do with the fact that fluorine deoxyglucose is a good marker of inflammation and infection as well as cancer. So anything that has a high metabolic rate may have elevated uptake of FDG on a PET-CT scan. So these are two scans. Here's showing a pulmonary nodule in the right lower lobe. This patient's pulmonary nodule has an SUV of 3.8. SUV is not a silly useless value. It is actually a relative measure of how much FDG accumulates in a target area versus the whole body. So usually the higher the SUV, the more likely it is to be cancer. Here's another patient with another pulmonary nodule, and this SUV is 4.8. So which one is cancer? Or are they both cancer? Or neither cancer? Well, actually, it's this nodule that's cancer, and this was biopsy proven. This is a consolidated pneumonia, and it got biopsied, and it was not cancer. So it depends on where you live as well, because in Texas, we have a lot of granulomatous disease. And so anybody who's had histoplasmosis, sarcoid, coccidiomycosis, those may all be hot. So just getting a PET-CT may not be the end of the road for working up your solitary pulmonary nodule. You may still end up getting a biopsy. Now, we turn to the amyloid agents. These are agents that are actually image amyloid deposition in the brain, and you've probably been hearing a whole lot about those. They became FDA approved about 2 years ago. They're now several different ones on the market. Medicare says we will not pay for this indication because they don't feel that there's sufficient evidence at this point that this benefits in any way the patient or the family. The nuclear medicine community is trying to fight this by providing additional information. For some of you, you may have been around when we did the National Oncology PET Registry, the NOPR, and that really opened up a lot of indications for cancers that Medicare was restricting at that point. And we hope to have a similar trial for the amyloid imaging patients. Most of the third-party payers will also not pay for it. So right now, if patients are interested in receiving this, they're basically self-pay, and the charge is around $5,000. And this is an example of amyloid imaging. This is an FDG PET scan, and you can see that there's reduced uptake of FDG in the parietal lobes consistent with a diagnosis of Alzheimer's disease. And this is an amyloid scan showing amyloid deposition in the cortex, and you can see all through the brain, you see deposition of amyloid. The problem with some of these agents is that the normal distribution is in the white matter. And if you've got somebody that has a lot of atrophy, the white matter and the gray matter may be very close together, and sometimes these can be overcalled. The other problem is amyloid begins being deposited in the brain at a fairly young age, in the 30s, and it increases as the patient ages. So the deposition of amyloid alone is not sufficient to make a diagnosis of Alzheimer's disease, and some of the other dementias also have amyloid deposition. So it's sensitive, but it's not necessarily specific. So my message to you is not to not order nuclear medicine examinations, but please consult with us and let us help you make decisions about should you order this or something else, or among the things that we have to offer, which one might be best. We also are very familiar with how much all of these things cost, and we're very familiar about what insurance will and will not pay for, so we can be very helpful if you let us be your consultants. And so if you do decide to send your patients to UT Southwestern, you might have a chance for them to pay a visit to the beach and lie on our nice SPECT CT scanner and look up at the ceiling of our very pretty display of a palm tree on a white sand beach. Okay, so now we have some questions for you. This is reminds me of Harry Potter, clickers at the ready. And all of the following are acceptable Medicare indications for FDG PET, except the staging of prostate cancer. And again, this is not because it just doesn't take up FDG very well, except in the very aggressive prostate cancers. And then about the appropriateness criteria, all of these are true, except they keep coming in. I can't stop yet. Okay, they're widely known about and used by referring physicians, and I think one of the messages from our today is that we're going to help you with the appropriateness criteria, and that this is something that we can work together to do the best thing for your patient, and thank you very much.